Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I'm going to be talking about treatment updates. I have no disclosures. And we're going to spend most of the time talking about cabotegravir, rilpivirine, or Cabril updates, and then briefly talk about the Deft trial, which is a trial looking at ART for drug-resistant HIV, and then briefly give updates about weight gain. But again, focusing mostly on long-acting Cabril. So of those updates, I'm going to spend most of the time talking about one study. And with the background as follows. We all know that the Atlas FLAIR and Atlas 2M studies have demonstrated efficacy, and virologic failures in Atlas 2M have occurred 2.3% as a virologic failure rate in the Q8 week arm and 0.4% in the Q4 week arm. And typically these occur pretty early. I believe, if I recall, about 70% or so occur in the first year. None of those studies that I mentioned included patients with viremia, including the treatment-naive study, which was the FLAIR study, because people actually had to be placed on 20 weeks of Triamec first before they could switch to the long-acting injectable. So I think this is no news to you all, especially since Dr. Monica Gandhi came and spoke to you all about this. But Ward 86 in San Francisco had published about their experience between June 2021 and April 2022, where 51 persons with HIV initiated rilpivirine Q4 weeks. 15 of that 51 had detectable viremia, and 12 of those 15 achieved viral suppression. And now I'm going to share with you an update from that data. So their update is that between the initial start date and November 2022, 133 persons with HIV started long-acting Cabril. Eligibility included willingness to receive Q4 week injections, and exclusion included a history of rilpivirine resistance and greater than one CAB mutation. Patients had drop-in access to clinic with rare injections, albeit some, in the community via street medicine. And in their cohort, 76 persons with HIV had viral suppression, and 57 did not have viral suppression, i.e. 57 people were viremic when they were starting the injections. Their results are as follows. First, they started off by sharing some demographics and clinical characteristics of their cohort, which you probably all remember a bit from Monica's talk, but I think things that are pertinent, there are many from this graph, but it's mostly that there's a fair number of housing instability, that 98% of patients were on Medicare or Medicaid or both, and there was a fair amount of substance use. And they wanted to point out, at least they pointed out at CROI, that the CD4 count in those who were virally suppressed was 616, and the CD4 count in those who were not suppressed, not surprisingly, was lower at 215. So some more pertinent results, perhaps, are that 74% had on-time injections. And I think that's important because for those of you who have implemented this, you know that there is a bit of phone calls and a little bit of, there's a fair amount of reminding inter-visit to ensure that people are coming on time. And in their cohort, about 3/4 had on-time injections. Among the 76 with viral suppression, 100% remained suppressed. And then among the 57 without viral suppression, 55 suppressed. They said at a median of 33 days. This was not asked specifically in the Q&A, but I'm kind of curious, did that suppression occur at a median of 33 days or whatnot? I'm just a little bit curious about that. The viral failure rate was 1.5% since those two people did not suppress, and those two individuals had their failure sort of manifest at less than 24 weeks. And by failure, I mean that they actually never achieved viral suppression since they were viremic to begin with. And I think what we mostly want to know is who were these two individuals? Well, not so much who they were, but rather what are some of their characteristics. So the first person started off at baseline with a V179 mutation and had a baseline viral load of 214,000. So already had some giravirine resistance, albeit potentially low, and a high viral load. At their first visit, their viral load went to 39,000, but did not go to undetectable. And so they subsequently did genotyping and found that they had a Y181C and an L100I. The second person started with a T97A mutation, which interestingly is a mutation that renders some resistance to the first generation instis, so raltegravir and elvitegravir, but per a Stanford guide, shouldn't have any resistance to CAB, dolutegravir, or bictegravir. And I think a lot of us think of that as a bit more of a puny INSTI resistance. And that person had a baseline viral load of 137,000, went down to 4,000. And that person developed an E138K and an RTI resistance and an R263K INSTI resistance. So, with that in mind, my conclusions from that were that people with HIV with viremia achieved high rates of viral suppression on Q4 weeks of CAB-RIL. Efforts at Ward 86 for those without viral suppression are resource intensive. I mentioned the drop in access, the street medicine, and notably for these individuals with viremia, incentives were used. This was not very clear at the conference, but did come up in the Q&A, and for this viremic cohort, incentives were used. I am curious how much, and we do not know those answers. And although they are resource intensive, Dr. Gandhi brought this up in her conclusions, but this is likely necessary to reach that last 10% of the population that isn't suppressed. In summary about the resistance, those two individuals did not suppress and had virologic failure less than 24 weeks into therapy. Both had baseline resistance, which prompted an intensification of the Ward 86 protocol to no longer allow any INSTI or NNRTI resistance, with the exception of a K103N. I am eager to see longer-term data and Q8-week data from this cohort. Of note, in the Q&A session, they did share that about a third of this cohort is now on Q8-week dosing, and that they are required to demonstrate viral suppression and on-time injections for 3 months in a row before they are eligible to switch to Q8 weeks. And I've included the website to the gettingtozerosf.org page, which actually has a link to the protocol. It's like 24 or 32, some multiple of 8 pages long, and available for you all if you are so interested. So that was the one that I was going to share the bulk of the time on, but I wanted to do a little bit of lightning round, as I've seen others do, with some other key long-acting cabotegravir-rilpivirine abstracts. I could spend hours talking about each one of these, so it's going to be a very brief overview of these, and I do encourage you to check them out online if you're interested in more details. But the first one will be the SOLAR study, looking at a switch from BIC-TAF FTC to CAB-RIL. Then a study coming out of France that looked at low concentrations of CAB-RIL in people with HIV, predictors of post-switch viremia from a UCSD cohort, and last, a poster of the pharmacokinetics of CAB-RIL administered in the thigh. So very quickly, in the SOLAR study, this was a ViiV-sponsored study, randomized controlled trial of 670 stable persons with HIV, by stable I mean virologically suppressed, on BIC-TAF FTC, who were switched to either CAB-RIL Q8 weeks versus continuing BIC-TAF FTC, and the finding was that viral suppression was non-inferior at 12 months. There were 5 virologic failures that occurred in the CAB-RIL arm, 3 with RAMs, and 1 had INSTI resistance at baseline, found subsequently on proviral DNA, and interestingly, all those injections were on time. 1 person had virologic failure in the bictegravir arm, but none of those individuals developed resistance. And interestingly, 90% in the long-acting arm preferred CAB-RIL after switching from BIC-TAF FTC. So that was SOLAR in 30 seconds. Next is the French prospective cohort of 58 virally suppressed individuals from 2 hospitals who were switched to long-acting CAB-RIL, and they followed them for a median of 8 months. They also measured viral loads and their trough concentrations, and they found that at month 1, 60, I believe it was, what I had to write this down, it was like 60% of people on CAB had low concentrations, and 30% of individuals on rilpivirine had low concentrations. And at month 3, 77% of people had low CAB concentrations, and again, around 30% of people had low rilpivirine concentrations. These are people taking it on time. Only 1 person had virologic failure. I've included the details about who that person was. Interestingly, their BMI was 29. They did not have an oral lead-in. The viral load was 2,800 at that month 1, and there was no treatment emergent resistance. And their trough values were a CAB value of 701 nanograms per milliliter, and rilpivirine was 28. As a threshold, which I had to look up when I went to this oral abstract, a value less than about 1,100 is of concern for CAB, and less than 32 is of concern for rilpivirine. And that's actually the same value that they used in the Cottrell article, where they looked at the predictors of failure. Interestingly, they found, and then they did some statistics to figure out what was associated with low trough values, and they found that no oral lead-in and high BMI were associated with low trough values. This is a French study, and so the median BMI in this study was 24, which is not very large, and the interquartile range was 22 to 26. So this is something that I wanted to highlight. And then at the UCSD, this will be very quick. There was a retrospective cohort of 144 individuals. They looked at viral loads greater than 20, 50, and 200, and they found that having at least one detectable viral load in the year prior to switch was a risk factor for detectable viremia post-switch. They did stratify these based on greater than 20, greater than 50, and greater than 200. Again, I care mostly about greater than 200, given that that's clinically relevant, but this was what they found. And then last, the poster from looking at the pharmacokinetics of Cabril in the thigh. This was a sub-study of 121 persons with HIV in Atlas 2M who had already received 3 years of gluteal injections, then took a 16-week thigh hiatus before going back on gluteal administrations. And their finding was that the difference in plasma concentrations between gluteal and thigh injections were not considered clinically relevant. And this was done in both Q4-week administration and Q8-week administration arms. There were, again, high rates of viral suppression, no confirmed virologic failure. 30% of individuals preferred a thigh injection. The median BMI here was 25. And unfortunately, though this is very helpful to figure out, especially for people who have contraindications to gluteal administration, what can we do? Can we give it in the thigh? This is not very extrapolatable because they had already been on 3 years, and then really they were like sandwiched by gluteal administrations. So we need more data on early thigh administrations and chronic thigh administrations before this is ready for prime time. And for those of you who are wondering, they used a 1.5-inch needle that went in at 90 degrees to the vastus lateralis. The right side got rilpivirine, R for rilpivirine, and the left side got cabotegravir. So that was all the stuff on Cabenuva. I'm checking my time, and we will quickly go through the next two sections, again, quite quickly. So Deft is the trial that we're going to talk about. As background, I know this is refresher, but the Dawning sub-analysis had shown us that dolutegravir plus 2 NRTIs, regardless of pre-existing resistance to one of those NRTIs, maintained viral suppression. And we remembered from that study that dolutegravir can fail with INSTI resistance, but boosted PIs generally do not fail with PI resistance. And in that study, the PI used was boosted lopinavir. I've highlighted that in blue because that's important because we're going to talk about some outcomes soon. In the Nadia trial, which was shared at CROI last year, and with a paper in New England Journal in 2021, the Nadia trial affirmed, again, use of dolutegravir with less than 2 active NRTIs in the setting of NRTI resistance, and showed us some results about TDF efficacy and superiority to AZT, and then also, for most of us, found some surprising results of TDF activity in the setting of a K65R. That is a bit of a digression. But ultimately, they reaffirmed, based on sort of what Dawning had shown us, that dolutegravir, again, can fail with INSTI resistance, but PIs generally do not. And the PI used here was boosted darunavir. And then there was the Vicen trial, which wasn't discussed much, but affirmed, again, use of dolutegravir or second-line PIs, lopinavir or atazanavir, as second-line therapy. So I think, again, most of us now know that with an M184V, we can use dolutegravir plus 2 NRTIs, is essentially the gist of that slide. So the Deft study, which stood for dolutegravir and darunavir evaluation in adults failing first-line NNRTI therapy, which is quite the stretch. They included people with HIV greater than 18 who had failed their first-line NNRTIs plus 2 NRTIs, but excluded individuals with prior PI or INSTI exposure who were Hep B surface antigen positive, had significant comorbidities or active co-infections, and who were pregnant or breastfeeding. They randomized those individuals to 3 arms. Arm 1 was standard of care, which is boosted darunavir plus 2 NRTIs. Arm 2 was boosted darunavir plus dolutegravir, and arm 3 was dolutegravir plus XTC TDF. Initially, this was just meant to be a 2-arm study, but because TLD, or tenofovir disoproxil fumarate, lamivudine, and dolutegravir is now first line in many parts of sub-Saharan Africa, they decided in May 2018 to add that. And here I've just written a little cheat sheet here, but that essentially think of arm 3 as TLD. So this was 830 patients in over 14 low and middle income countries, randomized to one of 3 arms. Stage 2 is really kind of what we're interested in because that was when they had all 3 arms. And this was a trial that kept a lot of people. There were only 7 withdrawals and 3 individuals lost to follow-up. Pertinent baseline characteristics were that the median CD4 count was 206, the median viral load log was 4.2, which is about 13 or 14,000, and there was no genotyping required. And as far as what ART people were on, what were they failing? 87 or 83% of people had failed efavirenz, 11% of people had failed nevirapine, and in the intervention arm, or the standard of care rather, the NRTIs used in second line with the darunavir-based regimen was 76% AZT3TC and 19% TDF-XTC. This is pertinent because in both Donning and Nadia, there was more equal TDF and AZT use, and here it seems skewed a bit towards AZT. Here are their outcomes, and again, I'd like to draw your attention to stage 2, where you'll see that the standard of care arm for them was 2 NRTIs plus darunavir, which got 71% viral suppression at week 48. The darunavir and dolutegravir arm was 85%, and the TLD arm, essentially, was 78%. And so that showed that TLD was non-inferior to standard of care, and then that the dolutegravir darunavir arm was actually superior, sort of exceeding the 12% non-inferiority margin. So, in conclusion, after failure with an NRTI plus 2 NRTIs, boosted darunavir plus dolutegravir was superior to that standard of care, and dolutegravir plus XCC TDF was non-inferior to the standard of care. They also saw that the mean CD4 gain at 48 weeks was greater in those intervention arms as compared to standard of care, and the mean weight gain at 48 weeks was greater in the dolutegravir-containing arms as compared to the darunavir-only containing arm. And the caveats from the study are that though the boosted darunavir and dolutegravir arm demonstrated superiority to standard of care, the availability and low cost of TLD as a fixed dose combination, which remember was non-inferior, that is widely available in many LMICs, is a key consideration when choosing ART. And just to not forget that the NRTI backbone used with boosted darunavir was mostly AZT. So, if that backbone had more TDF, would we not have seen that superiority? I'm not sure. So weight gain updates, lightning round again. I just wanted to put this up because as a reminder that, initially we thought maybe dolutegravir was a culprit in weight gain. Then in the advanced study in sub-Saharan Africa, we saw that the combination of TAF-FTC plus dolutegravir led to more weight gain than TDF-FTC dolutegravir or TDF-FTC efavirenz. The OPERA cohort showed weight gain when switching from a TDF to a TAF-containing regimen. That was most pronounced in the first 9 months after switch. But then at ID week in 2020, we saw results that showed that switching from TDF to TAF was associated with more weight gain than the switch from ABC or abacavir to TAF, suggesting that TDF was sort of weight suppressant. And then, interestingly, in Tango 144-week data, we saw that weight gain was occurring with both TAF-based ART and dolutegravir 3TC-based ART. So, quickly, I already mentioned the SOLAR study where people switched from BIC TAF-FTC to CAB-RIL. When they made that switch, that did not lead to weight loss. So we've been wondering, how are people going to lose weight? Another study looked at weight changes in switch to dolutegravir in Kenya, and of 23,000 persons with HIV, switching from efavirenz to dolutegravir led to weight gain, but switching from nevirapine to dolutegravir did not. So it's not just where you're going, but it's where you started. And I think this image really sort of, again, is worth 1,000 words, that if you're on nevirapine and switching to dolutegravir, not much weight gain. So what's going on with this anorectic effect of efavirenz? And then, whoa, big change to dolutegravir. And then lastly, the advanced study, they looked at a cohort of individuals who, after being on TAF, FTC, dolutegravir for 4 years, switching to TLD for a year led to weight loss in women with a median weight loss of 1.6 kilograms, but changes in weight were not statistically significant for men. So to wrap up, long-acting Cabril Q4 weeks is effective even in a cohort of 57 persons with HIV with viremia and is resource intensive, including incentives, though this is likely what it will take to end the epidemic. Some concerning data emerged regarding long-acting Cabril, including impact of baseline resistance, such as in the Ward 86 paper, virologic failure emerging even in the setting of on-time injections, such as in SOLAR. I need a comma there. Modest baseline BMIs, oral lead-in or lack thereof, and viremia in the year prior to switch. So this really, to me, just means that in people who are viremic, we can use Cabril Pivarine with a lot of innovation and with a lot of resources, but that in people who are stable, that I will continue to be conservative about the switch. That Cabril in the thigh seems promising, but is not yet ready for routine use. That after prior virologic failure with N NRTI plus 2 NRTIs, the Deft trial reaffirmed that dolutegravir plus 2 nukes is non-inferior to darunavir, and newly demonstrates that perhaps dolutegravir plus boosted darunavir is superior. And then last, regarding weight gain and ART, to consider whether the effects seen are actually due to anorectic effects of TDF or efavirenz and removing those, or are they due to obesogenic effects of TAF or dolutegravir. Those are not words I came up with. This was discussed at CROI, and it was kind of the first time I heard a lot of discussion about anorectic versus obesogenic, so wanted to share that news.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.